Welcome to the Patient Assessment Lecture in MRI. My name is Debbie Lamb and I'll be your course instructor. In today's lecture, we're going to cover patient assessment, how to properly communicate with our patients, cultural diversity issues, problem solving, patient transfers, and what to do with patients with special needs. Many steps are taken before the patient ever gets onto the MRI table. Responsibilities such as scheduling the examination, selecting the appropriate examination protocol, obtaining pertinent medical history, and preparing the MR examination room are often done in a group effort with technologists, clerical staff, and radiologists. The exact order of the steps and what staff member performs what duty varies from facility to facility. In this lecture, I'd like to discuss how we prepare our patients for scans through good communication skills. I'd like to talk a little bit about what's expected of us as well as what's expected of our patients. We're also going to need to be able to deal with patients who have special needs, so we're going to discuss that in detail and briefly talk a little bit more about patient safety. So let's begin by discussing communication and how important it is. We as MRI techs understand the importance of providing our patients with quality care, but what is often overlooked is the fact that in order to provide this care, technologists must have an attitude that is attentive, personal, and they need an interactive style that leaves the patient feeling cared for as individuals. Obtaining an accurate medical history and ensuring that the patient understands what is expected of them during their MRI scan are critical steps in performing a safe diagnostic test. Only through effective communication can this be accomplished. Good communication is essential during an MRI exam. We need to make sure that the patient understands not only the procedure, but also what is expected of them during their exam. We also need to continually communicate with them during the exam and explain to them that they have an emergency button that they should activate if they feel the need to come out of the scanner quickly. Let's begin by talking a little bit about verbal communication, the spoken word. Our vocabulary and the organization of sentences must be at an appropriate level for the patient. I'm going to give you an example of what I mean by this. For example, discussing units of radiation dose with a minister is probably not of any interest to him or her, but on the other hand, telling a physics teacher that a chest x-ray dose is similar to a few minutes of sun tanning is equally inappropriate. An important point to remember is that whenever possible, verbal communication should also occur face-to-face. This approach typically makes the patient and their family feel that they have your undivided attention, your concern is only for them, and they are the only person about whom you care at that particular point in time. Always be polite and focus your attention on the patient at all times. Remember that cultural and individual differences in people may affect their opinion of what you are trying to communicate. Be careful not to patronize or otherwise demean an individual. Let's talk about the value of humor. The value of humor in medical settings is well recognized. Using humor to relax and open up conversation is acceptable, but we must be extremely careful to avoid cultural slurs and references to age, sex, diseases, and the abilities of us as healthcare professionals. For example, if a patient asks about the specifics of a medical imaging procedure and the reply is, "Well, I don't know, this is my first time performing this procedure," although this response may be humorous to you, the patient may become hesitant about having an inexperienced person performing his or her examination. This apprehension may lead to closure of all communication channels between you and the patient. Now let's talk about nonverbal communication, things we may say or messages we may convey without ever opening our mouths. For example, the technologist should look at a patient and show interest in what they are saying. Smiling, responding truthfully, and using a friendly tone of voice all work in getting a good history from a patient. Sometimes negative nonverbal cues can also be used to improve the history. What I mean by that is, for example, if you have a puzzled look on your face, it may prompt the patient to elaborate on exactly how an injury occurred, and it may provide the radiologist with details on the direction of the force that caused a fracture. While speaking with patients, the technologist should avoid standing away from them with their arms folded across their chest. This body language is generally perceived as someone who is on the defensive. Eye contact may also help to ensure that questions, instructions, and other information have been understood. Patients also respond extremely well to touch, and using this technique is acceptable as long as you do it in a professional manner. The use of touch conveys to patients that the technologist is trying to understand and to be empathetic. Gentle support under the arm to assist patients to and from the imaging room and onto and off of the table often provides reassurance to the patient that he or she is being cared for by a qualified technologist. As far as personal appearance goes, I added this picture in just to show you what a sloppy appearance looks like. Although dressing according to a dress code does not produce a better technologist, a professional appearance in the medical setting says as much about a person as their technical abilities say about their competence. Professional dress helps the patient feel comfortable and confident in the technologist's abilities. Gaining the patient's confidence and trust is a considerable part of being a good, competent MR tech. Personal hygiene is as important as professional appearance. Personal grooming sends a powerful message. Unkept individuals may prompt patients to suspect that the person's professional behavior is similar to his or her appearance, neglected and messy. The use of strong perfumes, colognes, and aftershaves should try to be avoided. Patients may be allergic to certain smells or nauseated by the smell, and any smell may affect them. A patient will not communicate with someone whom they do not desire to be in close contact with. If the patient suspects that you are not sincere, then their anxiety level is going to rise. You are also going to have to move into the patient's personal space. This may make the patient uncomfortable, so you must tell the patient before you actually do this. Any problems with communication, whether major or minor, could have an impact on the patient's health care. If a patient leaves confused or misunderstood, he may not continue care that is necessary for his or her health. On the other hand, a patient that leaves feeling he was treated with respect and dignity will probably continue treatment. Remember, sometimes we are the first people patients see when they enter a healthcare facility. In order for you and the patient to communicate effectively, you need to use not only common sense but therapeutic or beneficial communication techniques. Patients want to feel important. They don't want to feel as though they are being passed around in an imaging department or that they are on an assembly line because you just want to hurry up and get the job done. They can sense when you are not sincere or when there is friction between you and a coworker. Some of the things you can do is establish guidelines. By introducing yourself to the patient and explaining the exam, a simple introduction can go a long way. Also, reducing the distance and facing the patient, making eye contact, also can go a long way. You should also be sure that you're in a quiet place in case the patient has any hearing issues. You should also not be performing any other tasks while you're talking to the patient. Being a good listener and actually looking at the patient when they are talking and nodding your head so that they know you have heard them helps incredibly with the communication effort. Using silence and knowing when to be quiet gives the patient a chance to think. Don't rush them. Let them take their time and tell you their story. Responding to the underlying message is when a patient expresses their feelings of either frustration, joy, anger, and you respond in a manner that lets the patient know his or her feelings have been heard and that you understand. Restating the main idea means repeating what the patient said so they know that they've been heard. Some communication habits that you should avoid. One being false reassurance. Don't ever tell the patient that everything's going to be okay when you don't know that for sure. Just let them know that you will take the very best care of them that you can, and you are going to get the best quality images that you are capable of. Also, don't ever ignore their wishes. If they want a family member to be with them, and it's okay for the exam being done, then you need to allow that. If they also refuse the exam, you should also abide by their wishes. Don't patronize them and talk to them like they're a child. Using language like honey, sweetie, and those kinds of remarks can be degrading to an adult. Although it seems harmless to you, don't get into that habit. Treat people with respect. You should Talk to them by using terms like ma'am, sir, Mr., miss, not honey or sweetie. Don't assume that you are not being heard. Be careful behind the control panel with what you say. Voices can carry and patients can hear way more than you think they can. Don't ever carry on a separate conversation across the room with a coworker about things like what you're doing this weekend or the next patient that you're going to be getting on the table. Patients don't care, and quite frankly, it's downright rude to do this when you're in front of a patient. Okay, so let's talk about patient expectations. Remember, patients have expectations of us just as we do of them. In radiology, particularly, the administrative focus is usually on reducing costs by increasing productivity. The efficiency of virtually every radiology department in this country is based on how many exams its technologists can complete per hour. This emphasis on speed means that technologists often must spend less time than they would like getting to know each of their patients. This can have a detrimental effect on patient satisfaction. Patients who are treated like bodies on a production line are bound to go somewhere else the next time they need health care. Patients who perceive a lack of genuine concern and empathy are the first to complain about their care and ask for their records to be transferred to another facility. Patients deserve and expect clean, articulate, concerned, well-groomed professionals to care for him or her. They also expect to be your main focus. Being able to communicate is just as important as being able to operate our complex equipment. During your practice, you are also going to have to learn how to effectively communicate with patients that are from other cultures. The relationship between culture and communication is an important part of our everyday life. Our reactions and habits are learned from our parents, are passed down to our children, and largely rule the way we conduct our daily activities. Each society develops unwritten rules regarding such ordinary things as how close we stand when talking to one another, where we might touch each other in public. We need to be aware of the diversity needs, expectations, and fears that may influence patients in the MRI department. The cultural differences in nonverbal behaviors are also something we need to think about. For example, a Vietnamese patient may smile to cover up anxious feelings. Repeated head nods may indicate respect for the individual speaking rather than agreement with the subject being discussed. Gestures, eye contact, and touch may have unintended meanings when perceived by someone from a culture that assigns different meanings to the same signals. Let me give you an example. Many Native Americans avoid direct eye contact, considering it a mark of disrespect. Many Asian societies make no eye contact during verbal communication and may resent direct eye contact, perceiving it as being impolite and an invasion of personal space. In some countries, eye contact and touch are less acceptable among adults than in the United States. Pointing directly at an individual can be considered insulting in many cultural groups, including our own, but it can be especially offensive to Native Americans and certain Asian groups. Signaling with the index finger is insulting to Filipinos and to Koreans. Another thing to keep in mind is how patients from different cultures feel about changing into a patient gown. Be aware that patients from a different culture may not want to change or don't understand, so you need to be sure to completely explain why you are asking them to do certain things. Let's move on now to patients with special needs. You're going to be interacting with patients who exhibit a wide variety of impairments. Combining common sense, empathy, and classroom knowledge will help you to provide quality scans for patients who would otherwise receive suboptimal examinations. Remember that the patient's cooperation is one of the main factors essential to producing a quality scan. Patients who are deaf or have impaired hearing require special attention. For persons who can read, the primary means of communication can be writing. The technologist may not insult the patient's intelligence by attempting to simplify terminology. Hearing does not control someone's intelligence, so please remember that. Pantomime and demonstration work well with hearing-impaired patients. For example, counting to 3 on your fingers, pinching your nose, and taking a deep breath symbolizes to the patient that you need him or her to hold the breath while you count to 3. Patients should demonstrate instructions in return to make sure that they understand. Many facilities offer deaf services and will provide a sign language expert as necessary. A blind patient or a patient who has decreased vision also needs special attention. The technologist should attempt to gain the patient's confidence as soon as possible by giving clear instructions before the examination, as well as informing him or her of what is occurring at all times. Reassuring the patient through a gentle touch establishes that someone is near if needed. Imagine the frustration you would feel if you were in a foreign country where no one understood English. Effective interaction with non-English speaking patients is significantly improved by using touch, facial expressions, and pantomime. Nearly all patients understand basic words such as yes, no, stop. Everyone appreciates any attempt to speak his or her language, even if only to say yes or no. Pronunciation and accents are quickly overlooked when good intentions are shown. Most hospitals maintain a list of bilingual employees who are available to help patients and visitors. For most MRI exams, patients will need to change into a light hospital gown and remove any metal that might be on them. It is our responsibility to direct the patients to the correct dressing area for gown changing and give dressing instructions. Patients should be instructed to use lockers for their clothing and personal belongings, such as jewelry, money, purses, wallets, cell phones, etc. Pediatric patients always require special attention. The proper method for dealing with young children is summarized by the famous statement of Dr. Armand Brodeur, a longtime chief radiologist at Cardinal Glennon Hospital in St. Louis. He says to stand tall in pediatrics, you have to get down on your knees. So in other words, simply getting down to the child's level physically, in language, and in spirit establishes a good relationship. Children are special patients who are capable of presenting a challenge to the MRI techs. A technologist who can perform scans effectively and competently on the pediatric patient is probably capable of handling any kind of MRI procedure on any type of patient. Patience, technical knowledge, understanding of the pediatric patient, and the use of good communication skills and immobilization devices can assist in obtaining a quality scan. Scans are most successful when the parents and patient are well informed. In addition, a relaxed, non-threatening environment helps gain the confidence and cooperation of the pediatric patient. A good MR tech, along with good cooperation of the parents, is able to scan the majority of children quickly, painlessly, and hopefully without the aid of sedation. Working with mentally impaired patients requires a thorough knowledge of equipment and immobilization techniques as well as interaction skills. Although degrees of mental impairment vary, using a strong yet reassuring tone of voice with these patients is important. You should not hurry, and you should try to be very patient with these patients. You may also need to interview the family for additional information. Direct questions toward the patient. This makes them feel important and involved. A continuous conversation while preparing the patient for the exam usually helps to keep the patient calm and relaxed. Let's switch our focus and talk about safety, both in the MRI department and in the hospital setting as a whole. While patient safety is a primary concern for all technologists, please remember to always ensure your own safety as you care for patients. MRI departmental safety is critical. It is important that you, as the MRI technologist, know what equipment is MRI compatible, and equipment that is not compatible should be clearly marked. Any equipment that may need to enter the MRI suite in case of an emergency must be MRI compatible. Oxygen tanks, wheelchairs, and stretchers should be made of aluminum. Sharps containers and hazard waste bins should also be MRI compatible and made out of plastic or cardboard. Before we talk about keeping patients safe, let's just talk about patient comfort for a minute. Lying on a hard MRI table is pretty uncomfortable. Patients are more comfortable with sponges or cushions strategically placed for support. We are responsible for the care of our patients while they are on our table. Padding placed under body prominences such as the sacrum, heels, or the lower back, is important for several reasons. One reason is that if patients are reasonably comfortable, they are better able to maintain the positions needed for their examination, even if they're on a hard surface. Another reason is that they may be older or debilitated, and these types of patients generally develop ulcerated areas over prominent bony structures when pressure is exerted for any length of time. These lesions are referred to as decubitus ulcers or bed sores. Sets of sponges in various shapes and sizes are usually available in the MRI department for this purpose. A sponge under the knees of a supine patient relieves back stress, and this is especially comfortable for elderly and kyphotic patients. Sometimes it may be necessary in trauma cases to use devices to keep the patients from moving during the imaging procedures. Restraints are used to ensure patient safety, and immobilization methods prevent undesired motion during imaging procedures. Restraints are used to prevent patients from injuring themselves or from disengaging therapeutic devices such as IV lines or oxygen masks. Although restraints may be annoying to the patient, they are neither painful nor harmful when properly used. Although it is preferable to win the confidence of a small child and have them willingly cooperate for the scan, and you know as well as I do, occasionally you're going to need to immobilize these kids. What I'm showing you here on the screen is a mummy wrap. This mummy wrap method is used to immobilize an infant or a small child. Many of you, I'm sure, have used this in diagnostic radiology at some point in time. Although it seems cruel, it doesn't really hurt them, and it will help you to avoid having to repeat scans. I'm not going to go through the steps, but if you do not remember or know how to wrap a child or need to refresh your memory, it is outlined in your patient care book. I'm also not going to spend a lot of time on patient transfer methods. Again, this is all outlined in your patient care book. When moving a patient from a stretcher to the table, there's sheet transfer, sliding board transfer, and a log roll. Before you transfer a patient, you should always check the patient ID, see if there's any restrictions or precautions, and always get assistance if needed. This is a two-lift method used to keep injuries from occurring for patients and staff members. This is an example of a three-lift person lift. This is possibly for someone who is paralyzed. Stretcher transfers. And there's different techniques for stretcher transfers. There's draw sheet transfers, slider boards. So please review all that in your patient care book. Now let's talk for a minute about incident reports. Any fall, accident, or occurrence that results in injury or potential harm must be immediately reported to the departmental supervisor and/or the radiologist if the patient should suffer an injury. As soon as the victim has been properly attended, complete an incident report. Reporting incidents is very important whether the victim is a patient, a visitor, or a member of the hospital staff. Do not hesitate to report incidents in which you are injured, either, even if the injury may seem minor to you at the time. If the injured person is a patient, the details of the incident must be recorded in the patient's chart. Incident reports are important to the institution's risk management program. They help in establishing or limiting the institutional liability for any injury and in documenting the need for changes that may improve safety practices in the future. Deciding whether a particular occurrence merits an incident report is a judgment call. For example, while a simple sneeze should not prompt an incident report, a severe asthmatic attack is a reportable occurrence. A very mild asthmatic episode that is successfully self-treated by an outpatient with the patient's own medication is an example of a situation where judgment will vary with individuals. The ability to make these kinds of judgments develops with experience. All students should consult a supervisor when such questions arise, but when in doubt, err on the side of caution by filing a report. And this is an example of what just a typical incident report looks like. Each institution that you go to will have their own version or variation of this. Like I said, if you're not sure whether to fill out an incident report or not, I would go ahead and do it. It's better to have more documentation than not enough. Okay, so on to patient assessment now. Special monitoring devices are generally not required for routine MRI examinations performed on stable patients. However, patients from inpatient units may arrive in the MRI department already connected to equipment such as monitors or a ventilator. Unstable patients and the equipment they arrive with must be watched carefully while in the MRI department. Because the technologist must focus on the scanning of the patient, a nurse or other health professional with the appropriate training should accompany these patients to provide the necessary monitoring and intervene should the need arise. We must also always remember that any special monitoring devices need to be MRI compatible. This is extremely important. It's important for us to notice the patient's overall health before the patient ever lies on the MR table. Patient assessment begins the minute you see the patient. Always document if your patient has, for example, yellow skin, a rash or hives, swollen extremities, if they're short of breath, if they're cyanotic, or if they're diaphoretic. All this is important information to document. This will help you, as the technologist, notice signs should some adverse event occur during the scan. If you are going to accurately assess a patient for change, remember, you first need to establish a baseline. What the patient is like before the exam starts is critical information, especially if the patient ends up having some type of reaction or incident. Throughout the exam, the patient should be monitored visually and spoken to frequently using the scanner's intercom system. This reassures the patient and allows us to intervene quickly should problems arise. Remember, document on the clinical history form any physical signs the patient is exhibiting prior to the scan. We also need to be sensitive to our patients' physiological needs while they are in our care. If they ask for a bedpan or urinal, this can cause embarrassment to the patient. Ask the patient if they would like to use the restroom before the exam starts. Always be sure if the patient does require a bedpan that the patient is covered for privacy. Suppose your patient asks for some water while they're there. Some medications or even just anxiety may cause patients to have dry mouth. If an inpatient requests water, always check with the nurse before giving, and if you do give any water to any patient, document how much you gave them and the time that you gave it to them. You can help make your patient more comfortable by just offering them a warm blanket. Sometimes this will distract them and get them to not think about that they're thirsty. Another responsibility of ours is to always check the chart. Nurses' notes are valuable information. For example, the nurse may have documented that the patient is unable to stand. This could tell you that the patient needs assistance, even if they say they can do it by themselves. This is also where you find an up-to-date history and physical. There may be information included here that the patient has neglected to tell you. The patient's most current lab values will also be in the chart. And also included in the chart usually is a list of all their medications, any allergies that they have, and any DNR orders that the patient may have. All of this information is crucial for you to know before you scan the patient. We as MRI techs always need to be ready for an adverse reaction. They are random and totally unpredictable. Therefore, we must be alert for physiologic changes in our patients. The best early indicators of a problem are changes in body temperature, pulse, respiration, and blood pressure. Collectively, all of these are called our vital signs. So it's important that we are knowledgeable of what normal vital signs are. So let's begin with temperature. Body temperature is most often taken by placing the thermometer in the mouth, the ear, the axilla, or in the rectum. In the MR department, the thermometer is most often an electronic battery-operated device with disposable protective covers. Make sure any thermometers that are brought into the MRI room are MR compatible. Most of the time, a temperature will only be taken on patients that are having an interventional procedure such as a biopsy, drainage, or possibly a myelogram. However, you should be able to take an accurate temperature if needed and know what normal values are. And I have given you normal values on this slide. Next, we need to know how to take an accurate pulse. A pulse is the advancing pressure wave in an artery caused by the discharge of blood when the left ventricle of the heart contracts. A pulse is an effective way to measure heart rate. Heart is measured in beats per minute. Patients in shock or with significant blood loss will have an increased pulse rate and rapid shallow breathing as the body attempts to supply oxygen to the tissues by increasing the speed of circulation. Remember, only MRI-safe equipment should be taken into the MRI room. And on this slide, I've given you average pulse rates for an adult. 60 to 100 beats per minute is average for an adult. Anything below 60 would be considered bradycardia. In general, the pulse can be felt wherever a superficial artery can be held against firm tissue such as bone. Some locations where a pulse is most easily felt are the temporal pulse, the brachial pulse, the femoral pulse, the popliteal pulse, the pedal pulse, the carotid pulse, and the radial pulse. Like I said, the most common site to take a pulse is usually the carotid artery, but there are several other sites you should be familiar with. Another skill we need is the ability to take an accurate respiratory rate. The respiratory rate is the number of breaths a person takes per minute. It is usually measured while the patient is at rest. It simply involves counting the number of breaths for 1 minute by counting the number of times the chest rises. Normal respiratory rates vary according to age. When patients show signs of respiratory distress, a respiratory rate will help in making an assessment. I've given you normal respiratory rates on this slide. I know that the advanced certification exams always like to make sure that technologists know what normal vital signs are. So please review all the vital signs that we've talked about in this presentation. Taking a blood pressure is another skill that we need to have. Blood pressure is defined as the pressure exerted by circulating blood on the walls of the vessels. The pressure is determined by the force and the amount of blood pumped and the size and flexibility of the arteries. Blood pressure is measured using a stethoscope and a blood pressure cuff. To take a blood pressure, you simply wrap the cuff snugly around the antecubital space, place the gauge for easy visibility, place the stethoscope over the brachial artery, and inflate the cuff. Release pressure while listening for audible pulses. Some institutions may require a baseline blood pressure before injecting contrast in any patient. For adults, the normal systolic pressure is 90 to 100 and the normal diastolic pressure is 60 to 90. For children, the normal systolic is 65 to 130 and diastolic 45 to 85. Usually males tend to have a little bit higher blood pressure. In our class session next week, I believe, we are going to be practicing taking vital signs on each other. One important thing to remember in the MRI department is you must always have a working blood pressure monitoring system and some type of O2 delivery system always available in case there's an emergency in the MR suite. I don't think there's a lot that you need to know about electrocardiography, but with more and more institutions doing cardiac studies, knowing how to put on electrodes is a necessary skill, and it's a good idea to be familiar with what a normal rhythm looks like and what an abnormal one looks like. Electrocardiography displays and records heart rate and rhythm through the use of electrodes placed on the chest. For monitoring purposes, only 3 leads are used. And I just wanted to go over kind of what a normal sinus rhythm looks like here. First you have the P wave. The P wave records the contraction of the atria. Then you have the QRS wave, and that records the contraction of the ventricles. And then you have the ST wave. The T wave represents the electrical change during the relaxation phase of the ventricles. Since the atria contract before the ventricles, there should always be a P wave preceding each QRS wave. And this is what we consider a normal sinus rhythm. And I've also shown you some abnormal rhythms. I've shown you ventricular fibrillation and atrial fibrillation. Both of these abnormalities, the heart would need to be shocked to put it back into a normal sinus rhythm. A pulse oximeter is a piece of equipment that you may need to use if you sedate a patient or if you're involved with any kind of interventional procedures. A photosensitive cell inside the oximeter detects the difference between oxygenated and deoxygenated hemoglobin. It works by passing a beam of red and infrared light through a pulsating capillary bed. It measures the difference in absorption between the blood that's pulsing and when it's not, in order to determine the oxygenation of the arterial blood. The ratio of red to infrared transmitted through the blood gives a measure of the oxygen saturation rate. A pulse oximeter is placed on a finger, toe, or earlobe, and normal values range from 95 to 100%. If a patient is on O2, check to see it is flowing correctly if the pulse ox starts to lower. I just wanted to show you a few oxygen delivery systems. Some patients may be on oxygen using a nasal cannula, others a nasal catheter, some may be on a face mask, some may be transtracheal, and others may be on a mechanical ventilator. So just a couple of different oxygen delivery systems. Okay, let's move on and talk about some common laboratory tests. As I previously mentioned, it's always going to be our responsibility to check the patient's chart for their most recent laboratory results. I don't think it's necessary for us to know what every lab test means, but it is a good idea to be familiar with the ones that may affect us. I would like to give you a brief explanation of what some of these abbreviations mean. CBC stands for complete blood count. This includes a white blood cell differential, a red blood cell count, hemoglobin, and hematocrit. ESR stands for erythrocyte sedimentation rate. A SED rate, or erythrocyte sedimentation rate, is a blood test that can reveal inflammatory activity in your body. A SED rate test isn't a standalone diagnostic tool, but the result of a SED rate test may help your doctor diagnose or monitor an inflammatory disease. Blood chemistry, or also called basal metabolic panel, BMP, is a group of tests that measures different chemicals in the blood. These tests usually are done on the fluid, which is the plasma part of blood. The test can give doctors information about your muscles, including your heart, bones, and organs such as your kidneys and liver. The blood chemistry panel includes a blood glucose or blood sugar level, a cholesterol level, calcium, electrolyte test, as well as blood tests that measure kidney function, which we need to know, which would be the BUN and the creatinine. Which brings me to my next point, which is main lab values that we are interested in, that tell us if the patient has impaired renal function, which is extremely important if that patient is going to receive any kind of intravenous contrast. BUN, or blood urea nitrogen, provides information about the kidney's ability to remove impurities from the blood. Renal disease impairs the ability of the kidneys to remove impurities such as MRI, intravenous contrast, and produces elevated BUN values. Creatinine is a waste product stored in the muscles as creatinine phosphate and then converted to creatinine. Since creatinine is normally removed from the bloodstream by the kidneys, elevated creatinine levels may indicate that there is an impairment of the function of the kidneys. Serum creatinine is usually between 0.8 and 1.6, but may be higher or lower. The kidneys normally remove creatinine from the blood. As kidney function slows down, creatinine levels will go up. Serum creatinine alone should not be used to assess kidney function because it fails to identify many patients whose kidney function is reduced while their serum creatinine is still in the normal range. In an elderly person, for example, half of kidney function could already be lost before the serum creatinine rises above the limit of normal. That's why recently most institutions have been requiring a GFR level on their MRI patients. GFR stands for glomerular filtration rate, and this rate is used to assess excretory function of the kidneys. GFR level is a measure of how well your kidneys are cleaning your blood, and the test will help indicate if a patient will have difficulty clearing the contrast. GFR is considered by medical professionals to be the best measure of kidney function. Knowing someone's GFR lets them figure out their stage of kidney disease. An estimated GFR is derived from a prediction equation. that takes into account patient factors in addition to serum creatinine. These factors such as age, gender, race, and weight closely correlate with the patient's muscle mass, which determines serum creatinine levels. That's why an estimated GFR is more accurate, because it accounts for the standard differences in muscle mass between people with different sexes, races, age, and body size. Two equations are commonly used in adults to estimate GFR, and they're listed on this slide. However, it is not necessary for you to know this formula, because you can just go to the website that I have listed and input your patient's information, and it will calculate a GFR for you. I also wanted to discuss some blood clotting tests that you will need to be familiar with, especially if you are involved with any interventional procedures. A platelet count is a test to measure how many platelets you have in your blood. Platelets help the blood to clot. They are smaller than red or white blood cells. Platelets are involved in the mechanism of forming blood clots. They are small cell fragments that do not contain a nucleus and are responsible for the plug which forms at the site of a puncture in order to stop the flow of blood. A significant reduction in the platelet count indicates that a patient may need blood under circumstances that would normally not result in bleeding. It is important for blood to clot adequately so that the patient will not hemorrhage from minor injuries or invasive procedures such as a biopsy or drainage. Low platelet count indicates risk. Another blood clotting test, called a PT or PTT, measures other clotting factors, and it is used to monitor heparin therapy. A D-dimer is a blood test used to rule out, diagnose, and monitor diseases that cause the blood to coagulate inappropriately. A positive test indicates the presence of abnormally high level of fibrin, a substance that is released as a blood clot breaks up. In the body, a high D-dimer indicates significant thrombus formation and breakdown in the body, but does not tell us where the location or cause is. Typically, a patient who has a positive D-dimer will more than likely go to CT for a PE study. I would like to talk a little bit about some acute care situations. You should be able to determine if your patient is in an emergency situation and recognize the signs and symptoms. Patients arriving in the MRI department may be experiencing a variety of physical ailments. Observing and communicating with your patient is essential. In most cases, the first action that you take in a life-threatening situation is to call the hospital emergency team, the physician, and co-workers to help you. In an MRI environment, the patient must be removed from the exam table and placed in a holding area before beginning any kind of emergency treatment. Cardiac arrest is when there's no pulse, no respiration, bluish color, vomiting, incontinence, defecation, and CPR should be started on any patient demonstrating cardiac failure. A seizure is a symptom of an underlying medical condition that can cause a patient to display convulsion signs, muscular contractions, facial twitching, blank stare, loss of motor activity, or difficulty breathing. Remove anything that may harm that patient. Stroke is a lack of blood flow to the brain. Signs of a stroke include inability to communicate, numbness, either unilateral or bilateral, paralysis, hypertension, incontinence. You should assess a patient's vital signs and get help. Shock is insufficient blood flow to the tissues or vital organs. This can occur because of loss of blood volume due to trauma or a surgical complication, or because of sudden massive vasodilatation. This is the case with anaphylactic shock, which can occur when a patient has a contrast reaction. Signs include altered levels of consciousness, hypotension, cool bluish or grayish skin color, tachycardia. You should keep patients warm with their legs elevated. Diabetic emergency is typically patients who have too much insulin in their system, which is a hypoglycemia, or not enough insulin, which is ketoacidosis. Patients may have tachycardia, complain of headache, blurred vision, or extreme thirst. Stop the procedure and notify the radiologist or nurse. With all of these situations, you should monitor the patient carefully until more qualified help arrives, and you should always measure and record a patient's vital signs. Some emergency equipment you should have on hand is MRI Safe Crash Cart, MRI Safe Blood Pressure Cuff, MRI safe stethoscope, and an MRI safe oxygen tank. Let's review some precautions we may need to take with patients that have some specific injuries. Over the next several slides, we're going to talk about patients with head injuries, spinal injuries, wounds, extremity fractures, and burns. Patients who have received a blow to the head could have serious injury without any external signs of trauma. A severe blow to the head causes the brain to kind of bounce from side to side, resulting in an injury on the opposite side of the blow. One way doctors evaluate head injury is by the Glasgow scale. This is a numerical scale that can be used to assess changes in a patient's level of consciousness. The scale is from 1, meaning alert and conscious, to 4, meaning comatose. Doctors grade patients on if their eyes are open, their verbal response, and their motor response. The earliest signs of increasing pressure may be irritability, lethargy, slow pulse, and slow respirations. Notify attending physicians immediately if you suspect a change in the level of consciousness of your patient. Unconscious patients should always have rails up on a stretcher and should never be left alone. The drunk patient is a difficult patient to assess. Don't assume that they are just passed out. These patients are subject to sudden changes in condition as a non-intoxicated person is. Be especially alert to changes due to alcohol intake. Let's talk now about some specific injuries. For example, spinal injuries. Even a slight movement of a patient with a spinal fracture may cause pressure on the spinal cord, resulting in paralysis or death, so do not allow or request the patient to move in any way. Cervical collars must remain in place during initial radiographic examinations until a physician has determined that it is safe for it to be removed. Observe patients for signs and symptoms of shock and monitor vital signs, and also get plenty of lifting help for these patients. Patients with open wounds have usually been treated before they come to the MRI department. Usually the bleeding has been controlled and dressings have been applied. Be sure to keep the affected limb immobilized. Inform the patient of any moves you are going to make and that may require their assistance. Do not remove any splints or other devices. Your primary responsibility is to maintain the dressings and report any significant amount of fresh bleeding. If a laceration opens, apply direct pressure to the site of bleeding while summoning someone for help. When moving patients with extremity fractures, 2 people must be present. When moving, always support the limb above and below the fracture site. This will help minimize pain, prevent damage to the soft tissue around the fracture site, and avoid the initiation of a muscle spasm. If moving a patient with a fresh plaster cast, undue pressure against it may cause it to change shape. Lift the cast by placing your hands underneath it. Never grasp from above. Observe the patient's fingers and toes for evidence of impaired circulation, cold, numbness, or lack of normal coloration. Any variation from the norm should be reported immediately to the nurse or doctor. Burns are frequently associated with respiratory problems, so you may encounter these types of patients if you work in a hospital that has a burn unit. When a burn patient needs an MRI scan, coordinate it with the nursing staff to be sure the patient has had pain medicine at least 30 minutes prior to the procedure. Patients may be under protective precautions to avoid infection. Patients may have grafts or healing skin that is extremely tender. Such tissue could be easily damaged during transfer to the MR table. Allow patients to move as much as possible by themselves. Use a transfer sheet to avoid abrasion, and be sure to ask for help. This concludes our lecture on patient assessment. Just remember that communication skills for all patients, including those with special needs, is very important. You should review any patient safety issues that I went over, such as how to move a patient and how to make them comfortable, how to take a set of vital signs, what the normal ranges are for temperature, blood pressure, respiratory rate, and pulse. Review the normal blood tests that we talked about. Know what a BUN is, know what a creatinine is, know what a GFR is, PT, PTT, what a D-dimer test is, what's in a complete blood panel, Pretty much everything that I've reviewed on here is up for grabs on a quiz. So, although all of this may be review for you, these are also very important things that you need to know as an MRI tech, and these are also patient care kinds of situations that the advanced MR certification exam may ask you about. So please review everything, please take good notes, and